So without further delays, I would like to invite Mohamed JALLOH, who is the senior behavioral epidemiologist with the U.S. Centers for Disease Control and Prevention. And Mohamed will speak to us about social mobilization. Just a second here, I lost the screen. Social mobilization as a strategy to increase vaccine acceptance and uptake. Welcome, Mohamed, over to you. Your microphone, Mohamed, it's on mute.
Oh, sorry about that. Thanks, Rafael, again for the introduction. And so I will be talking about social mobilization as a strategy to increase vaccine acceptance, or I should say vaccination acceptance and uptake. And the focus of my presentation will be more so on low and middle income country contexts. And I know we've seen a lot of other presentations, and we have other ones coming up that will talk about more US based context. But I do think though that the lessons that we've learned from LMICs, they have cross-cutting implications, and I do think that they can even inform some of the work happening in the US. So last year, we published this commentary in Human Vaccines and Immunotherapeutics, and we shed light on a lot of different lessons learned from social mobilization for immunization across various LMIC contexts. We look at Sierra Leone, we looked at India, we looked at Bangladesh, we looked at many other LMIC contexts. We looked at social mobilization during the routine immunization, during supplementary immunization activities, SIAs or campaigns, during the introduction of new vaccines such as HPV, as well as during outbreak response. And we identified some cross-cutting lessons learned. And today my presentation is really going to focus on some of those findings from this commentary that we published last year. So I won't go into a lot of details on every single thing because I think some of the other speakers coming up will elaborate on some of those points. But I do want to be able to provide a high-level overview and help to contextualize some of the issues and identify cross-cutting lessons learned that can build on the next set of presentations. Okay, so here's an outline for our presentation today. I will first try to define what is social mobilization, because I think that's important so we have common understanding, and then give some examples of successful implementation, highlight some challenges and limitations, and end with some cross-cutting lessons learned. So what is social mobilization? I think before we try to define social mobilization, it's very important to understand where the word actually came from. You know, in public health, we like to take credit for a lot of things and a lot of words that have made their way into public health and not even realize where they came from. So social mobilization, or the word mobilization, has its roots really in the military, referring to mass military mobilization, whereby you're planning well-coordinated military activities that are comprehensive and they go through a chain of command. And it's an important point that I'll get back to later. So just hold that thought. But here are some more functional definitions of social mobilization that I want to highlight. I really like these two definitions, and I'll highlight why. On the left, you have the UNICEF definition, which is widely used. And I think the key takeaway from the UNICEF definition is that social mobilization is a process and that it involves engagement. And I think this is a very important key word. And then you have on the right-hand side, you have a definition provided by Todd Rogers and colleagues from Harvard's Kennedy School. And they define social mobilization as a collective effort to achieve a collective outcome. And they also talk about how social mobilization imposes a net cost on each individual, and that, you know, the cost is not necessarily a financial cost, but can also be a social cost. But these two definitions have a lot of things in common. And I think the key takeaway point here is emphasis on social mobilization is really kind of a means to an end, and that end is to increase vaccination uptake. So I'm going to jump right in and give an example from Sierra Leone. This is a very early example of successful implementation of social mobilization. It's kind of what I would consider a very classical example of social mobilization. And I'll try to give some context and then explain what was actually done and what the outcome actually was that came from that social mobilization effort. So some of you may have heard of the UCI campaign, the Universal Child Immunization Campaign, which was a very, very ambitious campaign to get every child around the globe vaccinated by 1990 with 6 antigens. And by 1985, Sierra Leone was lagging, behind the rest of the world, even behind most countries in Africa. We saw that in Sierra Leone in 1985, coverage for the 6 antigens stood very low at just 6% nationally in the entire country. And the Ministry of Health, UNICEF, a lot of other partners tried to understand what the issues were. And initially, there was a lot of investments that went into what we are calling the supply side components, including improving and enhancing the cold chain. But what happened was that they didn't see any changes in the coverage. So by 1986, going into 1987, coverage was still hovering around 10%. And the Ministry of Health and UNICEF, they decided to do a CAP survey. And that CAP survey, I think, revealed so many important points. Some things were things that we can take for granted now. But, even in the context of Sierra Leone at that time, they didn't even have a local word for the word vaccine. So that was one of the first things that came out, that people didn't even understand what word to use to describe it. And if you don't have the word to describe something, it makes it really hard to talk about it. So that was one lesson. And then second, you had people didn't know where and when to get vaccines or to get their children vaccinated. And then what they also saw was that there were lots of people who felt like vaccination was not aligned with their religious belief, their traditional beliefs, and for those reasons decided not to vaccinate. So that those findings were then used by the government of Sierra Leone with very close support from UNICEF and other partners to design a very robust national social mobilization campaign that went from national level to district level down to chiefdom and community level throughout every single district in Sierra Leone. A key part of that engagement was, engaging religious leaders. So that was a really, really key focus of the social mobilization strategy, especially with the finding that, a lot of people did not believe that vaccination was aligned with their religious beliefs. So UNICEF and the Ministry of Health, they actually organized the religious leaders into 2 action groups. They call them the Christian Action Group and the Islamic Action Group. And I should note that in Sierra Leone, about 95% of the population either identify as Christian or Muslim. So it was very important to engage these 2 groups. But what they did that I think was really important for us to note was that instead of going to these leaders and just giving them messages and ask them to go out and disseminate messages, they went to them, explained what the problem was, and brought them in as partners. And then the leaders themselves said, you know what, we have some solutions here. They went into the religious text and identified messages to support immunization, because they said, well, if we're going to go and talk to our people, we have to use the language that they understand. And I think that was an important step. So they identified these messages and developed them, and then they trained their fellow imams and pastors from national level down to district level, down to the community level. And the structure that the religious leaders had was very powerful because they were well organized and they were all over the entire country. They were probably more organized than parts of the government, to be truthful. And so that platform was so important to be able to reach every corner in Sierra Leone with these very, very important, not just messages, but messages delivered through very influential messengers. Going beyond the religious leaders, they also engaged the media, school teachers, traditional institutions. The paramount chiefs were brought in as ambassadors for immunization. And then what you saw was that by 1990, we saw this dramatic improvement, perhaps one of the largest increases in vaccination coverage in any country within this period of time, where vaccination coverage went from 6% to 75%. And I think that was celebrated and made news splash around the world at that time. And the reason why I went back to this very classical example is because I think a lot of the issues that were being trying to be addressed are still some of the issues that we're dealing with today, almost 30 years later. And something else we saw from the Sierra Leone example was that when you make investments in social mobilization, even though these structures might be difficult to keep and maintain, you can easily repurpose them. When Sierra Leone had the Ebola outbreak in 2014, these structures from the UCI era were quickly leveraged to be able to implement wide-scale social mobilization across Sierra Leone. And I think that's an important lesson also to keep mind of. Like I said, I won't be able to go into every single example we talked about in the commentary, but also I think it's important to note that in India, social mobilization played a critical role in the polio eradication program there. And our colleagues, Coates and colleagues wrote this paper that I think it highlights very important lessons that if you have some time, I highly recommend reading. And in Bangladesh, in 2018, in the Rohingya refugee camps, we saw similar issues. So even though the vaccines were available, to the earlier point mentioned by Dr. Ornstein, it's not vaccines that save lives, it's people and vaccination itself that saves life, not just the vaccine. So there's a critical example from Bangladesh where the vaccines were available on the camps, but people were not getting vaccinated. And the issues were not well understood. And so what we did, working with UNICEF, WHO, and many other partners, was to try to figure out what the issues were. And I won't be able to go through all of them, but one thing we identified was that the Rohingya population thought that when you get vaccinated, when you get a scar, and in Islam, that scar will be seen as tattoo, and then when you die, you will go to hell. I mean, that is a very complex notion that there is no way we would have been able to understand that if not for the assessment. So then we used that data in real time to go back and inform the next campaign that was coming up. And what we saw was that we brought the religious leaders in, some of the other traditional healers, the women leaders on the camps, and we were able to increase the coverage for the next campaign by more than 10 percentage points. So what are some of the challenges in social mobilization? The challenges are many, and I won't be able to go through all of them, but I think these are some of the recurring challenges. And there's a theme here. It's around people, it's around money, and it's around evaluation. And I won't be able to go through all of them. There's few ones that I want to highlight. There's this issue of not having adequate budgets and not having specific budgets for social mobilization. And social mobilization becomes kind of an afterthought, usually when there's a problem or during campaigns. So you have this issue of the one-off-ism. And over time, communities also get fatigued because you come and talk about one issue over and over, and they have many other issues that they're looking at in terms of well-being, going beyond just immunization, talking about their social interests and other economic interests that they see as priorities, and they wonder why you keep talking about just one issue. So that was also a problem that we've seen. And finally, this issue of risk monitoring and evaluation. Fortunately, we have colleagues that will be talking about some of those later. So some key lessons learned, and I know I'm running short on time, so I'll be faster in the next set of slides. I think this is a very important point. One, I think it's important to avoid the spare tire problem. Far too many times we've seen social mobilization being seen as an afterthought. Only when there's a problem, then you say, oh, okay, let's get together and do social mobilization and try to see what we can do to address the issue. If that is how you're operating, there's a problem. The reason why I mentioned this, going back to that example I gave about social mobilization having its roots from the military. In the military, when they do military mobilization, it's not something that just happens when there's a problem. It's not something that happens just by a few low-level soldiers. It's something that has the buy-in, that has the involvement, the engagement of the generals down to every single person who is involved. So it's not a matter of one or two people. It's a matter of everyone being involved. So I think in immunization, we really need to see the entire immunization as one big social mobilization effort. This point, I think, has been said already many times that social mobilization should not be confused with message dissemination. It's not just about the messages. I think it's been said already, it's about how those messages are delivered. And I think that goes to this next point as well. It's about getting the right people, not just when it's time to say, well, we have some things we want to do, let's bring people to help us implement it. Even when you're thinking about and designing your social mobilization strategies, it's really important to bring in people from the community and helping you to design your strategies. And I think this has been said already, but we cannot say it, we can keep saying it, that the messenger is equally as important as the message. And we can add that in how the message is delivered can be even more important. If you take our friend here on the right, you know, he has a very powerful message he's carrying on his back, but it's not just that message that influences people. It's who he is, what he represents to those communities that will make them listen to him and want to engage with him. And hopefully that can help increase vaccination uptake. And there are lots of things we can learn from behavioral science. And I think that is very important to make sure that when we're designing these strategies, we're building on top of what we know from behavioral science. And I've highlighted a few ones that I think are really important to make the behavior observable, normalize the behavior so that vaccination is the norm, align the behavior with how people would like to see themselves, and to leverage existing community structures and influence spheres. Last but not least, I think this is so important to be able to use standards. When we say social mobilization, when we talk about community engagement, what are we talking about? I am so excited to see this recent document that UNICEF published that highlights the minimum quality standards and indicators for community engagement. I think it is so important because it helps us think about how we design high quality social mobilization and even how we evaluate them to understand some of the more process oriented issues with social mobilization. And also, I think finally, social mobilization is not a one size fit all. It will never be perfect. And we need to continue to generate the data to inform the strategies as we move forward. So thank you very much. I'll stop there.
Thank you, Mohamed, for that very interesting historical perspective on social mobilization, which was a key intervention and continues to be a key intervention in vaccination campaigns and was critical to the child survival revolution in the 1980s and 1990s.